Good morning, everyone, and welcome to the 2022 Illinois Reentry Conference. We are super excited to have you with us today. The theme of today's conference is Advancing Health, Criminal Health, and Social Justice. My name is Rashonda Johnson, and I am a manager at Public Health Institute of Metropolitan Chicago. For the past 5 years, I have been fortunate to manage our Community Reentry Project, which is a multi-stakeholder initiative that coordinates reentry efforts in Illinois. Today, I have the pleasure of serving as your conference moderator. Our conference planning team has put in a great deal of work to curate today's conference, and I can honestly say that you are in for what promises to be an amazing day. Now, before we hear from our first presenter, I'd like to walk you through a few items that can be accessed on today's conference platform website. First is our main stage and chat. Here is where we will gather for all of our plenary speakers and for guidance throughout the day. You will have access to the chat, which you can use to engage with one another and our speakers. Feel free to use the Q&A feature for any questions you have for our speakers or team, and we will do our best to address them as we go throughout the day. Secondly is our conference agenda. Here you will find your roadmap for the day. Forget where you're supposed to be? Well, you can refer back to the agenda to see what is happening throughout the day. Next is our breakout rooms, which is where you will find session topics and descriptions, which you can use to determine which room you like to participate in. Next is our speaker bios, and that's where you can go if you want to learn more about today's speakers. And finally is our supporters tab, which is where you can find this year's supporters of the Illinois Reentry Conference. We like to take a moment to thank the Illinois Department of Public Health for their partnership and to this year's conference sponsors, which is HIV Care Connect, Illinois Public Health Association, and ViVE Healthcare, which you will learn more about throughout the day. You will also find a live Twitter feed where we invite you to tweet throughout the conference. Use the hashtag Illinois Reentry to share your thoughts and or aha moments. We hope that you find the conference platform easy to navigate and accessible for all of your conference needs. We also want to note that the conference webpage will be available for 30 days post-event if you need to refer back to it for any content shared here today. This year's conference will focus on helping each of you rediscover, reimagine, and rebuild best practices in criminal health and social justice. We will address topics such as building healthy communities, reentry needs and resources, HIV, COVID-19, and so much more. All of this will be with the focus on how each of these impacts the justice-involved community. Our goal is that you not only take away a fresh perspective, but that you also take away tips and tools that will help you now and in the times to come. Now, before we proceed with the rest of the day, we want each of you to know that PHIMC is committed to creating a safe space for all attendees today. We want everyone to know that this is a safe space where you can be fully self-expressed without fear of being made to feel uncomfortable, unwelcome, or challenged on account of race and ethnicity, sexual orientation, gender identity, or expression, cultural background, and or experiences. Let us do our best to make sure everyone's voices and experiences are heard, and we ask that you remain open to learning something new that you can take back to your spheres of influence. Thank you so much for joining us and for showing your dedication to this important work. Now that we've got all of that out of the way, we'll move into our agenda for the day and introduce our first speaker, Dr. Fredrick Echols, who is the current commissioner of the City of St. Louis Department of Health. He previously served as the acting director of health and was the first medical doctor to serve as health director since 2007. Prior to serving as the acting director, Commissioner Echols served as director of communicable disease, vector and veterinary programs for the St. Louis County Department of Public Health, chief of communicable diseases for the Illinois Department of Public Health, and as a physician in the U.S. Navy, where he managed a staff of medical and ancillary personnel. As you can see, we are in very good hands this morning. Commissioner Echols will be discussing reentry and public health, So at this time, please help me welcome him.
Hi, my name is Dr. Fredrick Echols. I'm the Health Commissioner for the City of St. Louis. Today I'll be talking about reentry and public health. The focus will be identifying how the local public health system works and the role for local public health agencies as well as corrections facilities and other members of the local public health system to work together to really improve access to health and social support services for the reentry population. I have no conflicts of interest to disclose. The mission and vision of the City of St. Louis Department of Health is the cadence that determines the frequency of activities that we implement, as well as how we engage community around significant issues such as reentry and services that we render for individuals, for services that we make available for the reentry population as well as the incarcerated population. The mission for the health department is to assure a healthy St. Louis community through quality public health services and partnerships by providing continuous protection, prevention, and promotion for the public's health. The vision for the City of St. Louis Department of Health is a St. Louis, an equitable community achieving optimal health for all. We have a few objectives for this presentation. Over the course of this presentation, we look to achieve the following. One, we want to review the role of public health in the local public health system, discuss the health disparities and inequities that exist among the reentry population, discuss barriers that prevent the reentry population from successfully accessing health services and social support services, and discuss some approaches that can help the reentry population access health and social services more efficiently and effectively. First, we're going to look at public health practice. This is something that we talk about day in and day out in the public health realm, but oftentimes there's a disconnect between how we interpret public health practice and how other people within the local public health system determine reference public health practice. Before we talk about public health practice, I also want to look at the local public health system. So oftentimes individuals think of the local public health system as only being the local public health agency or the health department within their jurisdiction, but it extends far beyond the boundaries of the local health department. According to the Centers for Disease Control and Prevention and other organizations such as the National Association for County and City Health Officials, the local public health systems includes organizations such as the EMS services, corrections, law enforcement, faith-based communities, nursing homes, laboratories, the health department, of course, elected officials, fire, EMS, and a slew of other organizations within a particular jurisdiction. And so it really requires a public health approach really requires the system working together. But in order for the system to work together, we have to be able to identify the key stakeholders within our jurisdiction. So as we talk about reentry, oftentimes people only associate reentry with the corrections facilities and some service organizations, but the entire system is also responsible for making sure that services, particularly health services and social support services, are available for the reentry population. Then we look at how public health practice is defined. So public health practice is defined as something that's conceptually broad, but is understood as the collection and analysis of identifiable health information by a public health authority for the purpose of protecting the health of a particular community, where the benefits and risks are primarily designed to accrue to the participating community. And so when we think about public health practice, particularly in the city of St. Louis, our efforts impact every population within our jurisdiction, including those who are incarcerated and also those who go through the reentry process. And the work that we do really extends far beyond just health services, which include medical screenings and so forth, but also connecting individuals to those social support services, such as housing, utilities, support, and other essential services that are necessary to give individuals a fair opportunity to achieve optimal health. When we look at the origin of public health practice, the history of public health is a narrative that entails individuals and groups seeking for an effective means of protecting the health of a population. It is derived from many historical ideas, trial and error, the development of technology, and epidemiology. In the modern day era, James Lynn's clinical trial of various dietary treatments of British sailors with scurvy in 1756, and Edward Jenner's 1796 discovery that cowpox vaccination prevents smallpox have modern day applications as the sciences and practices of nutrition and immunization are crucial influences of health among the population across the world, but especially population that we consider to be our most vulnerable. The history provides a critical context and perspective to develop an understanding of health problems and communities and how to cope with them. And so oftentimes what we do in public health is we look at the history of service delivery for our most vulnerable population to determine the best path forward. As we all know that the incarcerated population and the reentry population are all disproportionately affected by things such as chronic illness, such as heart disease, diabetes, as well as issues such as substance use disorder, issues with recovery, and mental and behavioral health. So understanding how services have been delivered for this particular population is really critical when we think about making sure we connect individuals to services as they re-enter civilization. And as we focus on historical trends as it relates to access to health services, we also have to look at the trends as it relates to morbidity and mortality for particular groups. So previous studies reveal empirical data to the mounting evidence that racial and ethnic minorities are at elevated risk during previous pandemics. Existing health disparities increase the likelihood of severe clinical complications following communicable disease infection. Reports have discussed differential exposure or susceptibility as potential sources of racial ethnic disparities in hospitalization rates, and studies confirm that the existence of significant racial ethnic disparities in potential exposure risk, susceptibility to complications, and access to healthcare. If the results are generalized to the United States population, this will be cause for urgent action. And so as we look at the issues related to disparities among certain populations, we know that certain individuals have higher risk for not only having certain medical conditions, whether it's chronic or acute conditions, but also the complications associated with those conditions. So when we think about the reentry population, as well as those who are incarcerated, oftentimes they are disproportionately impacted because of their history and their exposures. And so it's really important for us to look at the history of communicable disease and disease transmission and disease prevalence among that population, and the root causes for disease prevalence amongst that population, so we can truly address the root causes while they're incarcerated, but also we can connect them to the appropriate resources when they look to re-enter civilization. Some of the disturbing trends that we've seen as relates to all-cause mortality is well documented with the Centers for Disease Control. When we look at data going back to the late 1900s, it's really troubling to see that a lot of the disparities that were present back then are still present now. Although the 1918 non-white gap is what we call a non-white gap, meaning that looking at cause mortality for non-white groups and white groups, this is how they were classified then, and all-cause mortality cannot be linked exclusively to public health emergencies such as pandemics, because mortality gaps have been reported in non-pandemic years. Sustained gaps in influenza and pneumonia and in influenza mortality were evident in subsequent years. For instance, between 1929 and 1931, influenza mortality per 100,000 persons was reported to be 71.3 among non-whites and 30.3 among whites. Higher 1918 influenza mortality and case fatality rates among non-white populations in cities and urban populations also revealed a 1918 non-white gap in influenza mortality. Today, a non-white white gap may also occur because the non-white populations are far more concentrated in cities. 27% lived in urban areas in 1910 and 90% do so now. 49% of whites lived in urban areas in 1910 and 75% do so now. And also crowding and high population density in cities are also well-known risk factors for transmission and respiratory infectious diseases. And we also have to look at the settings within which the incarcerated and the incarcerated population where they live. So there's oftentimes the perfect storm, if you will, or the perfect environment for transmission to occur in jails and prisons, And when individuals are released, oftentimes that can reintroduce or introduce diseases and conditions into the communities where they are being where they're being placed. So making sure that there's good public health practice and infection control practices within the correctional facilities is really important, because that really sets the tone for individuals prior to reentry. So make sure they have not only good infection control practice, but also making sure that those incarcerated individuals have access to quality health services, particularly preventive health services, is really critical to giving them an opportunity to achieve and maintain optimal health. And when we look at previously recommended recommendations for populations, a lot of the recommendations that have come down the pipeline over the course of the last few decades continue to be the same. So one being culturally competent preparedness and response that address the racial ethnic minority populations, improvements in public health and community health safety net systems, social policies that minimize economic burdens and improve compliance with isolation and quarantine and other mitigation measures, relevant, practical, and culturally and linguistically appropriate tailored communications, ensure undocumented immigration status does not present a barrier to the healthcare of immigrants, as well as including racial and race ethnicity data in public health and hospital reporting. These are things that have been recommended year in and year out for several decades. However, when we look at the health outcomes for incarcerated populations and populations that are in the reentry population, it's really important for us to understand what policies need to be in place to make sure that they have an opportunity to achieve optimal health. When we look at the burden of disease, particularly for mental and behavioral health, substance use disorder, some chronic conditions such as HIV and other sexually transmitted infections, as well as hepatitis, it's really important for us to understand why the reentry population and the incarcerated population have a higher risk and higher prevalence of those conditions. And then we also need to go a step further in making sure that we have an opportunity, or they have an opportunity to receive appropriate treatment while they're incarcerated and be connected to quality health services and social support services upon reentry. When we think about reentry, and when you look at it in a silo, most people think that it should be a relatively simple thing to accomplish. However, when we look at the system in detail, we know that there are significant challenges for individuals who are looking to reenter civilization. And so we know the United States that we incarcerate more people than any other country in the world, having more than 2 million adults behind bars at an estimated annual cost of $182 billion annually. A 500% increase in incarceration in the United States during the last 40 years was not merely a result of rising crime, but also a result of the increasing criminalization of behaviors exemplified by the war on drugs, incarceration of people with serious mental illness, and increased sentencing for disadvantaged individuals. Black and brown individuals are substantially overrepresented among incarcerated people. Contemporarily, the root causes of the phenomenon point to longstanding structural oppression. People released from incarceration have a high risk for adverse health outcomes and death due to pre-existing behavioral health and chronic medical conditions and the negative effect of incarceration itself. Compounding these problems are barriers to health care and basic social determinants of health, such as shelter, food, and employment. When we look at mental and behavioral health issues for the reentry population, we know that individuals reentering society have significant challenges because they have they often experience higher rates of suicide, disabilities and physical disorders, homelessness, and even death. The reentry population also has disproportionate rates of communicable diseases, as I mentioned before, such as sexually transmitted infections, including HIV and AIDS, and hepatitis C. It's also really important for us to understand the barriers to accessing services for the reentry population. Being released from incarceration affects a person's ability to secure basic needs such as health, housing, and employment. Compounding these barriers are issues related to the returning to impoverished communities and complicated relationships with families and support systems. And that's really one really important point, especially particularly when individuals are returning to the community where they were once planted. Oftentimes, as we look at least in the city of St. Louis, the disparities that exist across the city of St. Louis, our most vulnerable neighborhoods are often the neighborhoods that are under-resourced, underutilized, and have a lack of quality health services available to individuals who may need them. And so that creates access issues that sometimes individuals are not able to overcome. The intensity and complexity of the issues that individuals face differ for those living from prisons versus jails, and it's also important for us to understand that as well. After being incarcerated for years, persons released from prison may leave without an official identity card, or they're more likely than people who have been in jail to be estranged from family and frequently return to communities geographically distant from their place of incarceration. However, there is an element of predictability that can facilitate release planning and programming. In contrast, most people leaving jail have been incarcerated less than a month and will return to local communities where they may still have social support intact. However, short-term and often chaotic jail stays are coupled with variable access to physical and behavioral health care and pre-release coordination with community-based programs for people in jail is less likely than people in prison settings. So that network of support typically is not there for individuals leaving prison. So oftentimes we really need to make sure that there's a stronger support network or a network of service providers or agencies that can really help individuals re-enter society and get connected to the services that they need. One important thing that we also have to be mindful of is oftentimes when individuals are incarcerated, they historically they've been excluded from Medicare and Medicaid, so they lose their medical benefits. And although individuals may receive health services while incarcerated, upon reentry, there may be a gap between them being released and getting connected to a public insurance option. We know that the federal law requires suspension or termination of Medicaid benefits on incarceration, and efficient systems to reinstate Medicaid on release are really uncommon. There was one study that found that 28% of jails screened for Medicaid eligibility at release, and researchers identified many other barriers to Medicaid enrollment. Furthermore, as the 2010 Affordable Care Act did not anticipate rejection of Medicaid expansion in 12 states, many low-income returning citizens in those states do not qualify for Medicaid and are ineligible for health insurance subsidies under the federal marketplaces. So even after individuals get released from prison, they encounter barriers just obtaining medical coverage. And oftentimes a lot of the service organizations may not be aware of their state's policies and protocols for getting individuals re-enrolled. And so making sure you have the right stakeholders at the table during the reentry process is really critical to make sure that we remove as many barriers for individuals so they can again obtain access to health services and quality social support services upon reentering society. A few additional barriers to accessing health services include, education and literacy levels, as well as returning to neighborhoods that are under-resourced, as I mentioned before. So again, knowing that individuals who are incarcerated are have a higher likelihood of having lower education attainment and lower literacy levels means they may need additional support upon reentry to help them navigate the system. It's many of you all who are listening to this broadcast are aware of the challenges that you all that are in place when you're trying to navigate the medical system. Imagine trying to navigate the medical system, the healthcare system, having low education attainment and low literacy levels. That creates significant barriers for individuals, as well as barriers to employment for those individuals. And so making sure that, again, you have a network of providers that can really assist with, help the individual assist with transitioning back to society is really critical upon reentry. One of the challenges that we face in the St. Louis area is that there oftentimes is not a coordinated approach for reentry. And so that oftentimes leaves an individual left to fend for themselves after they've been released from jail or prison. And so knowing these challenges gives us an opportunity to really identify opportunities to improve reentry. And so one thing that we do in public health that really sets the tone for everything that we do is making sure that we're informed about evidence-informed practices. And one of those things is addressing bias. So oftentimes, when we think about the incarcerated population, not only do they have the challenges of trying to overcome issues related to their past, but addressing bias among the staff that are designated to support them is really important. And we really need every individual that's a part of the reentry process to understand and move in a manner that suggests that all individuals deserve to be treated as whole and human. Meaning that they too, although regardless of their past and their history, they have a right to access health services, social support services. And if you're in that position to really assist them, that you do all you can to do that in a culturally sensitive manner. Because failure to implement those activities in a way that an individual feels respected and feels invested in, that can really create additional barriers for that individual to access services after being released from prison or released from jail or prison. And it's also important to incorporate evidence-informed programming into the reentry program. And some of the latest evidence has shown that cognitive behavioral therapy and therapeutic communities have really shown to be beneficial because it has helped individuals identify areas where they thrive, and that has given people a sense of hope. So the evidence has really supported utilizing that approach and implementing that type of programming in your reentry program. So as individuals are getting prepared to return to society, they can have a better mindset and a better sense of self. Because we know that traditional programming during reentry and post-release tends to focus on a person's deficits, such as criminal cognitions, antisocial behaviors, substance abuse, and antisocial peers. This focus reinforces the person's identity as an outcast. So desistance research calls for more attention to programs devoted to helping people assume citizenship, identity, and reframe their identity to be more pro-social. So an example of that is a program that was developed in Florida, and it works to identify transformation efforts, and it's known as the 5 key model for reentry. This model was developed and tested by Florida State University, and while they were creating the model, they identified the 5 key ingredients likely to best promote successful reentry. And these 5 key ingredients include healthy thinking patterns, meaningful work trajectories, effective coping strategies, positive social engagement, and positive interpersonal relationships. And so programs that have the greatest potential to reduce recidivism generally use therapeutic modalities such as I mentioned before, cognitive behavioral therapy and therapeutic communities to address substance use disorders, mental illness, and criminal cognitions and values. These modalities focus on building resilience in the person and improving decision-making to address challenges such as influence of peers, housing instabilities, and interpersonal relationships. Prisons and community-based supervision agencies tend to have few programs that involve cognitive behavioral therapy and therapeutic communities. The lack of clinical programming is generally a result of an emphasis on life skills programming, such as preparing for work, finding housing, and opening bank accounts. For the most part, life skills programming is easy to provide because it does not require clinical staff and can be delivered using videos and work groups. One other important key that is critical for individuals in law enforcement and corrections to understand is also intersectionality. And so, put simply, intersectionality is the concept that all systems of oppression are connected. So we think about the incarcerated population, the reentry population. There's a lot of issues that they're dealing with that really disadvantage them when you look at how society receives or responds to them versus their counterparts, which are individuals who do not have criminal histories. So more explicitly, the Oxford Dictionary defines intersectionality as the interconnected nature of social categorizations such as race, class, and gender. And we would also add criminal history, regarded as creating overlapping and interdependent systems of discrimination and disadvantage. Intersectionality forces us to acknowledge that everyone has their unique experiences of discrimination and oppression, and we must consider everything and anything that can marginalize people, again, such as gender, race, class, sexual orientation, physical ability, and criminal history. To create lasting change, public health and health authorities must be willing to confront the source of inequities and intersectional public health responses. To do this, we must consistently collect information that will facilitate the identification of inequities across multiple accesses of oppression. And particularly as we look at the reentry population and the incarcerated population, there's a special set of barriers, special set of challenges that have not really been addressed in the United States. And as we look to provide support for them, it's really important for us to understand those barriers so that we can, again, connect those individuals to the resources and provide the proper support that they need to have a fair opportunity to thrive upon release. The other key, as we look at individuals being released and how we connect them to services, when we think about implementing evidence-based approaches, we have to make sure that we focus also on data management and dissemination. The lack of evaluation of reentry program is really problematic in the United States. And so as we implement these programs and try to connect individuals to services, it's also important for us to understand how effective implementing those services are. So the collection and reporting of disaggregated data to document inequities is a central role, not only for the local public health agencies, but also for agencies across the local public health system, which includes our corrections facilities. It is insufficient for although disaggregated data is typically insufficient for intersectional analysis, failure to describe why identified disparities exist implies that the source of health inequities lies within the specific individual or groups who bear the burden, and suggests that poor health is an innate quality of certain groups rather than created and maintained by systemic oppression. And so as we work to understand the root causes of the inequities, it's also important for us, as I mentioned prior, to make sure that we are able to develop a plan and really an evidence-informed plan to make sure that we are not causing additional harm to individuals who are members of the reentry population or the incarcerated population, but that we're really giving them an opportunity to access quality services so they can have a fair chance at achieving and maintaining optimal health. And last but not least, engaging the local public health system to improve release coordination. A major challenge that we found in the city of St. Louis is, as I mentioned at the beginning of the talk, that most people don't know what the local public health system entails. Most of the time, they only think that it's the public health agency in their jurisdiction. But as I mentioned before, it extends far beyond the boundaries of the local health department. It covers or includes corrections facilities, fire EMS, social support agencies, the hospital systems, medical service providers such as federally qualified health centers. All of these organizations have a role to play in helping ensure individuals get connected to the right services. However, when you're creating reentry programs, you don't have the right individuals or the right agencies at the table. You can create barriers unknowingly for individuals who are trying to get connected to services. And so, as you look at the agencies that you partner with for your reentry program, really look at them really closely to identify, the services they provide. It's also important to understand whether or not they provide quality services that are compliant with national recommendations as it relates to cultural sensitivity. Because we also know that individuals can be, because of stigma and bias, they can be treated unfairly, even when they attempt to receive social and medical clinical services. Now, just spend a few moments just thinking about how what the future looks like for reentry and public health. Today, I said that the future outlook for public health and reentry is really promising, um, but it requires a lot of additional efforts on behalf of local public health agencies and how they engage the local public health system, as well as individuals who are part of the reentry process. A couple of things that have really come to light over the last few years is the need for criminal justice reform, really reforming how the system works. So reducing arrests for nonviolent offenses, enacting bail reform, mitigating sentencing practices, as well as providing scaling up compassionate release. In addition to that, increasing federal and state support, including through expansion of Medicaid programs. In this, I believe in the state of Illinois, Illinois is a Medicaid expanded state. The state of Missouri just recently, in 2021, voted to expand Medicaid, and so we're still working through issues with that. But making sure that individuals are connected to Medicaid or whatever eligible public insurance option they're eligible for is really important upon release, so that there isn't a large gap between the time that they're released and when they can access essential medical services. States should also supply for Section 1115 waivers to provide Medicaid coverage while people are incarcerated. So although there are federal statutes that require individuals to lose their Medicaid or Medicare coverage upon incarceration, there are some avenues that agencies can take to request waivers for individuals so they can maintain their Medicaid coverage while they're incarcerated. Other important thing is to invest in the evaluation of reentry programming. As I mentioned before, there's very little research that's been done on reentry programming to look at the effectiveness of the programming that's being implemented across the nation. And so it's really important to really evaluate the effectiveness of the program. The way you can do that is partnering with academic institutions, partnering with the local public health agencies and other specific organizations that focus solely on evaluation of program activities, to really obtain a better understanding of how these programs are working or not working and create a better path forward. And last but not least, improve release coordination through the establishment of partnerships across the local public health system, as I said before. So identify those partners who are currently at the table. Also, it's important to look at those organizations who may be able to provide support, but they may not have a seat at the table as it relates to the reentry programming. And so identifying these partners is really critical, because without the right partners at the table, health screenings, social support services will likely not be provided in a manner that really meets the needs of individuals who are members of the reentry population. With that, I want to say thank you for your time. It's a pleasure speaking with you all today. And now I will open up the floor to answer any questions you may have.
Thank you, Commissioner Echols, for your talk this morning. Super great way to start the day. So now we're going to open up the floor for some questions. We're going to take some time just to see what the audience, what questions they have for you. So if you do have a question for Commissioner Echols, go ahead and put it in the Q&A box at this time, and then we're going to ask. So we're going to just kick it off with our first question that we have. So Dr. Echols, you mentioned incorporating CBT and reentry programming. Do you have any examples of similar programs that incorporate these type of practices, and whether they are in correctional facilities or in other organizations?
Yes, that's an excellent question. So in the city of St. Louis, our correction facility has an independent medical provider for the city. It's Horizon Healthcare. And so although they don't provide some of the cognitive behavioral therapy within their staff, there are agencies across the city of St. Louis that they bring into to the correction facility to provide training and special sessions for individuals who are interested. And they do this on a monthly basis. And so by making sure this is not only just attached to the reentry process, but also it's made available for all individuals who are incarcerated, has really shown to be proven to be impactful and effective amongst the group that are interested. And we found that creating access to these critical services has really improved individuals' ability to comply with recommendations as it relates to being incarcerated, as well as giving individuals a sense of hope and a sense of investment, like they feel that there's hope for them. And so I think, again, as I mentioned during the presentation, do an analysis, do a survey, look at the organizations that are in your area. And now with telehealth services, you can also look at individuals across the nation who may be able to provide cognitive behavioral therapy training from a distance. And so this is a very valuable resource, and it just takes a matter of really reaching out and seeing which organizations not only have the capacity to do it, but which organizations are qualified to do it, particularly for the incarcerated population and the reentry population.
Thank you so much. Definitely is a capacity thing with everything going on with COVID. I'm sure everybody is pretty stretched, but I do appreciate, that encouragement to start to get some of those programs in that focus on CBT. So we have another question coming in. How should organizations assess the COVID-19 pandemic when evaluating their programs and their services?
That's a really great question. So my approach with correction facilities in the city of St. Louis at the beginning of the pandemic was, one, making sure that they had an infection control plan in place. So what we found across the board was a lot of organizations, whether it's schools, communities of faith or faith-based organizations, as well as government organizations, really developed tunnel vision and just started focusing on COVID-19. But it's really important for organizations to have a comprehensive infection control plan so that it doesn't depend on a public health emergency for us to update and bring our practices up in compliance with national recommendations. So having a comprehensive infection control plan is critical. We also one of the things we looked at really closely was visitation. So we look at visitation, particularly during COVID, because of the way SARS-CoV-2 spreads. We knew that bringing individuals, particularly from the community, especially when there was high transmission in our community, we knew that would place greater risk on not only the staff that were working in correction facilities, but that could potentially lead to outbreaks within the facility. And so early on, we discontinued in-person visitation. And that really helped us slow the spread of COVID-19. Over the first year, we had less than 100 cases in our facility because of that. And so when we think about infection control practices, it's something that we have to be mindful of all the time. But we also have to make sure that staff are aware of the importance of infection control training in properly implementing infection control measures day in and day out, not just during times of a public health emergency. And so in order for that to happen, you really have to change the culture of the organization and the staff. So making sure, again, that infection control practices are a priority. And when that's done, you really can see the difference, and you can provide a safer and healthier environment for the incarcerated population day in and day out.
Yeah, that's really good. Having a plan in place is really important because then we're not scrambling as much and we have something that we can go off of. So I really appreciate that. Another question that's coming in, someone says at their clinic, they notice that their patients that are experiencing incarceration are lost after establishing care. What would you recommend for them to keep them in care?
Right, so case management is really important. So we look at case management really closely when we're thinking about, in the general community setting, when we're thinking about substance use disorder, mental behavioral health, as well as other conditions, particularly sexually transmitted infections, including HIV. Case management is really important. So that same approach can be implemented in correction. So if individuals falling out, they're not following up with their appointments, if you have case management staff available, have them follow up with them regularly just to see how they're doing, and then also give them reminders of their upcoming appointments. the more touch points you have with an individual, the higher likelihood that they'll be able to and willing to comply with any medical treatment recommendations. But along with that, you also have to make sure that the approach is culturally sensitive. Oftentimes, what I've seen is people can become numb, or they can start acting on their own bias as it relates to individuals who are incarcerated. And so, really implementing a culturally sensitive approach when you're contacting them, if you have multiple touch points between appointments, that's really critical to keeping them engaged, as well as, again, changing the culture of how the organization provides medical and social support services.
Yeah, that's good. Thank you. Case management is a huge piece to reentry. So thank you for that. You drop in really, really good nuggets. So we appreciate that. So we have another question that's asking specifically about, in your experiences or, from your knowledge, how can organizations actually get the word out to jails or prisons about services that they might be able to provide?
So oftentimes it's the corrections facility. So in the city of St. Louis, we have the Division of Public Safety, which is responsible for overseeing the correctional facilities. And so working with the administration team is really important. And they are oftentimes the ones that will need to reach out into community to figure out which organizations have the capacity and the expertise to provide quality services to the incarcerated population. And so oftentimes they can contact the health department. So one of the challenges with government systems is oftentimes there are silos that really limit our ability to leverage resources and connect with one another. And so working with the local public health agency is really important as well. Establish a strong relationship with the director or the program staff, because oftentimes we have information about medical service providers, social service providers across the region where our agency is planted, and that information can be made readily available, and we can actually serve as a liaison connecting the correction facility to a particular organization. And so don't underestimate the capacity of your local public health agency, because they have a lot of resources that are available, and oftentimes those resources are underutilized because individuals aren't aware of the resources that are in the community. And the other thing that's important is that oftentimes these service providers receive funding either from the local government, the state, or even from through the federal government to offer services to disadvantaged populations, which oftentimes includes individuals who are incarcerated, individuals who are working to re-enter society. And so again, working with your local public health agency to get information is really critical. But then also extend the olive branch to some of the other networks that are out in your community as well, because oftentimes we have a lot of information at the public health agencies, but we may not have all the information. But we can connect you to resources as best we can.
Thank you so much. You actually just brought us into the segue of the next question, because somebody actually asked, how do you engage or reach out to a city department, particularly around reentry programming?
So that's a great question. So the simple thing to do is you can pick up the phone, call the health department, ask for if there's a group that's really focused on criminal justice reform or reentry. Oftentimes there can be case management staff in the health department. Ask for that particular program and they can connect you. Or if you have a list of different types of service providers that you're looking for, when you call the health department and get connected to someone, tell them that this is exactly what I'm looking for, and then they can connect you as well. The other thing you can do is you can send it, if you're not comfortable calling, you can also send an email. Email works just as efficiently, and oftentimes it's better because you have a paper trail of information that has been provided to you by the health department. But I think making sure that the administration of your facility is aware is really important, because oftentimes they may be aware of points of contact at other agencies that you may not be aware of. And so making sure that you follow the chain of command within your organization so that you have proper awareness within your organization so that everyone who needs to receive the information receives it as well.
That's so good. Thank you so much. You have given us some homework today to do some reaching out. And I really appreciate it. Just the power, I feel like you said a lot around the power of collaboration and like being able to reach out to different agencies and entities to move some of this work ahead. So I really, really appreciate just your tips and tools on that and sharing that with our audience today. So that is actually all the time that we have for questions. But Commissioner Echols, before we let you go, are there any last minute words or comments that you would like to make to our audience?
Yes, I think one of the things that that has been highlighted year in and year out as we looked at the disparities that continue to impact the incarcerated population, the reentry population, those chronic diseases, diabetes, heart disease, those things that we oftentimes take for granted in the public sector. But preventive health is really important. And we've seen that over the course of the COVID-19 pandemic. So one of the challenges that I've had to combat in St. Louis area is people just developing tunnel vision, just focusing on COVID. But when you look at the individuals who experienced the worst outcomes when infected with SARS-CoV-2, it was those individuals who had underlying medical conditions. And so when individuals are incarcerated, they have an opportunity to not only receive quality care, but they can be more closely managed compared to individuals in the public sector. And so really working to emphasize the importance of preventive health is really important. We know that Black and Brown individuals are often disproportionately impacted. Not only do you have a higher rate of incarceration, but they also have a higher rate of diabetes, heart disease, chronic lung disease, and these other things that increase their risk for severe complications. So really emphasize the importance of preventative health, and you can have the public health representative coming to your organization, a medical provider coming to your organization to speak to the group. But it's really important that they get that message, because that really sets the tone. Their understanding of preventative health and access to quality preventative health services really sets the tone for their life, not only while they're incarcerated, but even after they reenter society.
Yes, that's amazing. Definitely got to do more of that. So thank you for those last words. I think those were super impactful. And just overall, thank you for your time and your knowledge today. You've done an amazing job with setting the tone for our day. And I really think it's going to set us up for the rest of the day. And I'm sure that everyone is so grateful that you were able to join us this morning. So thank you so much for being here.
Thank you for having me.
For impactful partnership. PHIMC is committed to expanding capacity of healthcare and public health systems to promote health equity and expand access to care. Partners like you make this possible. So, with that being said, this officially concludes our 2022 Illinois Reentry Conference. We hope that you will be well, be safe, and have a wonderful evening. Thank you for joining us.